No. Okay, great.
Hey everyone, welcome to tonight's webinar. My name is Rajat, and along with Maggie Chung, I am the co-chair for the RFS Communications Committee. On behalf of the Society of Interventional Radiology Resident Fellow and Student Section, thank you for taking your time out of tonight to be here for this informative webinar on vertebroplasty and the currently existing trial data. Before we hand it over to our presenter, I want to remind everyone that this webinar will be recorded and will be available on YouTube in the coming days by searching IR Education. Anyone is free to ask questions at any time throughout the webinar simply by entering them into the question box on your GoToWebinar control panel. We'll keep a track of them and answer them at the end. Also, please check the RFS website regularly for upcoming events and follow us on Twitter and Facebook for other updates and posting of clinical IR material. It is my pleasure to now introduce our speaker for tonight, Maunik Patel.
Hi, thank you very much, Rajat. And thank you everyone for tuning in tonight. I'm going to talk today about 3 of the trials that are in literature for vertebroplasty and kyphoplasty, and also kind of go over some of the basics of the procedure. This is meant to be educational, directed towards residents and fellows, so I hope I can give you some useful information. Part of the reason why I chose this topic, I'm on the pain service line, and I thought this would be appropriate, but I also had an opportunity to do a lot of vertebroplasty procedures during my neuro-IR rotation last year. And my attending and mentor encouraged me to look at these trials to kind of think about, what we were doing, whether it was justified by the literature, whether it made a lot of sense to me. And so without further ado, I'm going to start with a case. So we have a 65-year-old lady, history of osteoporosis, prior DEXA scan, and she's at her primary care doctor, and she's got 11 out of 10 back pain, really bad. It's getting worse. She had an MRI a couple of months ago, and it showed some degenerative changes, but the primary care doctor was really worried, thought maybe there's even potential cord compression, and so they got a stat MR right away. So I have a sagittal STIR image here that I'm going to scroll through, and you can see right away there's high signal in multiple vertebral bodies. And the reports show that there was acute fractures of L2, 3, 4, and even to a lesser extent L5, but no signs of acute cord compression. One of the things that we do at our institution, we have a good relationship between the neuroradiologists and the neurointerventionalists. And so we actually put into our reports if we think that there is an acute fracture that might benefit from intervention to suggest vertebral augmentation. And so that's what was put into the report for this patient. It's how she presented to me. I'm going to talk a little bit about vertebral augmentation before we get further into the case. So it's a procedure that really came into vogue in the 80s and early 90s. With the advent of bone cement, people got the idea that they could potentially inject this into the spinal vertebral bodies to help with fractures. And so they used a transpedicular approach with a large trocar needle, and eventually got this indicated for osteoporotic fractures that were refractory to therapy, standard therapy. And so the goal of this is to reduce pain for the patient and also to reduce opioid dependence, which I'm sure you all know is really in vogue these days in terms of the national press. A schematic right here of what that looks like. So we have the trocar coming in through the pedicle into the compressed vertebral body. And slowly under fluoroscopy, bone cement is injected until an adequate fill is achieved. The needle is removed and the patient then goes on to recovery. It's not a procedure that it's without risks. One, given the real estate that we're working in with the spinal canal right there, you could cause direct injury. And so it's really imperative that the trocar is placed under close guidance. Trajectory has to be perfect. And if there's any sign that you're going off trajectory, you have to pull out and start over again. And so Aside from that, though, there are some other complications that are directly related to the bone cement itself. And really, it's the pressure that we worry about. And so when injecting the bone cement, you worry about the cement leaking either directly into the spinal canal, causing a compression, or perhaps into the neuroforamina. But also, if the pressure is high enough, cement emboli can form. And so this is through Babson's venous plexus, as we all know, is on the anterior and lateral sides of the vertebral body. And so when the cement gets into these vessels, it can cause direct cord infarct, can also go to other parts of the bodies and cause pulmonary emboli and so on and so forth. There were big cases in the 90s, and so this is definitely one of those things that you hear about quite a bit. Also a little bit about terminology. What is vertebroplasty versus what is kyphoplasty? The main thing is kyphoplasty uses this balloon tamp as part of the procedure, and the thinking behind it is we minimize the risks associated with these high pressures that are needed to inject the cement. So the balloon is inserted through the trocar and inflated to create a little cavity, and then the cement can then just be injected at a lower pressure into that cavity. There's some thinking that this improves the height loss because you're kind of improving, you're blowing up the vertebral body before you even inject any cement, although this hasn't been actually shown in the literature. There's also a thicker cement mixture that can be done with kyphoplasty as opposed to vertebroplasty, and so that also is potential benefit. As far as comparing the two, there haven't been any direct trials, but there have been a few meta-analyses that really don't show much of a difference between the two procedures. So with our patient, as we mentioned, there were multiple levels that were fractured, and so we had 4 trocars placed in her, all on the right side, or left side rather. And so you can see right here we have appropriate position through the pedicles. And then we did balloon tamps 2 at a time, and slowly under close fluoroscopy, both AP and lateral, we injected the bone cement. And this was our final result. So at our institution, we try and fill the vertebral bodies with as much cement as possible, keeping in mind that we do risk potentially extravasating the cement either into the spinal canal or into the venous structures. So, sometimes we'll change levels in the middle of the procedure. We'll inject at one level, wait for that cement to harden, come up, inject over there, and then come back to the level we were before just to get as much in there as possible. And I think we did that in this case. So this lady, she went from having unbearable 11 out of 10 pain, which improved to about an 8 out of 10 in the short term. And unfortunately, I don't have any long-term information about how she did after she left the hospital. But it did get me thinking, is this clinically meaningful? And my thinking on this is it really depends on the patient. For some people, going from an 11 out of 10 to an 8 out of 10, it can make the difference of getting up in the morning, taking care of what they need to do. But for other people, they could say, hey, it's still an 8 out of 10, and I went through this risky procedure for very minimal relief. So again, I think it depends on the patient, and I think it's something that I want to bring up as we look at the trial data going forward. So what does that data actually show? I'm going to start with the first trial. This is the INVEST trial. It was in the New England Journal of Medicine in 2009, and it was one of the biggest news-making trials in this field. It involved 130 patients, mostly in Australia, and they had to have at least 1 compression fracture at the thoracic or lumbar level. The pain score had to be at least a 3 out of 10, which is something I'm going to address later, but I just want you to make note of that. And the fracture had to be less than 1 year old per report, or if we didn't know the age, it had to have either an MRI or a bone scan that showed that this was an acute fracture. Patients were then randomized either to the vertebroplasty group or to a sham procedure. And it's interesting with the sham procedure, they actually would bring the patient into the room, inject them with lidocaine, mix up bone cement, make it feel like they were almost actually getting a kyphoplasty done, but or vertebroplasty, but not actually doing the procedure itself. Their primary endpoints, so they wanted to assess pain and pain-related disability at 1 month, and they used this thing called the Roland-Morris Disability Questionnaire. And it's an example of that questionnaire. So it basically asked the patient all these questions like, does my back pain limit me from getting out of bed? Does my back pain ruin my day? Does my back pain, you know, is it painful all the time? So on and so forth. A couple other things that they looked at, this pain frequency index, or basically how often are they having pain, how bothered they are by it, and how many opioids they're using. So if you look at the data that they presented, you'll notice that there really isn't any significant difference between the vertebroplasty group and their control group, which is the sham group. And so this is on either the pain intensity score or this disability questionnaire. And it was at all of these time periods that they measured. The secondary outcomes also not significantly different between the two groups. You'll see that the lines for the control group and the lines for the vertebroplasty are almost identical for all of these measures. And so even though they demonstrated that there was improvement in all these primary measures between the two groups, there wasn't a significant difference with the vertebroplasty groups. And there's no difference in the secondary outcomes. So this led them to conclude that vertebroplasty was no better than placebo. Now, by saying that, you know, you're going to invite a lot of criticism, especially from you know, people in our field. And you know, this paper was not without its flaws. So a couple of the criticisms, one, that a sham group is not a true control. So what I mean by that is, you know, they did, you know, this procedure, they injected lidocaine, that may have potentially confounded the results, maybe gave the patients in the control group a little more relief from their pain. But also, you know, a real control group in the clinical world is having you know, medical management. That's what we would do if we weren't going to do a procedure on the patient. They also included people with pain levels as low as 3, which I don't know if that really makes a lot of sense. A person telling me that they have a 3 or 4 out of 10 back pain, do they really get the procedure? You know, in the real world, not likely. They you know, included patients with subacute or chronic fractures, at least, you know, possibly. You know, they kind of went off report to whether the fracture was within a year, and even maybe a year is a little bit too long to wait. They had the option to cross over. So I didn't tell you guys this, but they did in their trial allow people to cross over from one group to the other group after a month. And interestingly, much more people that were in the sham group crossed over to actually get the vertebroplasty done than patients that were in the vertebroplasty group. And then finally, the follow-up period was only 1 month. And, you know, that I think was probably too short, and we'll see that in some of the later trials, they followed patients a little bit longer than that. The second trial is going on at the same time as the INVEST trial, and this is the VERTOS II trial. It was published a year later. And this was a randomized controlled trial, but it wasn't blind, it was open label. So the patients and the investigators kind of knew what they were getting. This was done in Europe, and they were randomized to either a vertebroplasty group or just conservative management, so more of a true control group. They specifically wanted to find people that were more acute than the INVEST trial did. So they had to have had, you know, obviously a compression fracture of at least 15%, had to have edema on MRI, less than 6 weeks of back pain. So really, you know, focusing on, you know, 6 weeks acute patients, And they use this visual analog scale, which I'm sure you've all seen in a clinic somewhere. Basically, you have a score over here is a 0 or 1, doing pretty good. Score over here, 10, really bad pain, causing me to cry all the time. So they wanted a score of at least 5, which I think is much more reasonable for including patients in the trial. They also wanted focal tenderness on clinical exam. So their primary endpoint was using this visual analog scale. They wanted to measure pain relief both at 1 month and 1 year. And they also checked it at various other measurements, 1 day, 1 week, 3 months, 6 months. And they checked a couple other secondary endpoints. One was on cost effectiveness, quality of life, and they also used the Rowland-Morris Disability Questionnaire as the INVEST trial did. We can see right here on their primary endpoint that at all of these time points, vertebroplasty had a lower VAS score than conservative management did. And it was significant even within a few days. It went from an average of 8 out of 10 to about 4 out of 10. They also demonstrated some improvement with quality of life and the Rowland-Morris scores. The information about the cost effectiveness, I didn't think it really applied to our healthcare system in the US, so I kind of neglected to mention that in here. So their conclusion was that if it's done within 6 weeks of onset of symptoms, that vertebroplasty can lead to quicker and greater pain relief. So I think this trial had a lot of strengths over the prior one. One was the longer follow-up. I think their control group was a lot better, as I alluded to before. And their selecting criteria was also a lot more specific, really looking for acute patients. And then they also allowed a crossover rate, but their crossover was a lot lower than in the INVEST trial. There also were a couple criticisms of this. So half of the patients that were evaluated initially weren't included in the actual randomization. So they actually had spontaneous improvement of pain before they were randomized. And they kind of alluded to this in the paper, but they didn't really kind of flush it out. It makes me wonder, if someone has an acute fracture, are half of them going to get better anyway? Should we be doing the procedure? And then, there's some people that have questioned the validity of VAS as a primary endpoint. I think it's a reasonable one, but that's certainly out there if you go digging. It's an open label trial, so there's the possibility of selection bias. And, they also collected some data on opioid use, but they never presented it. I'm curious to what that data might have shown. More recently, we have the VAPOUR trial. This came out in 2016, just last year. And this was also done in Australia. As actually some of the investigators that were involved in the INVEST trial. And they used the same sham protocol as the INVEST trial. And so these patients, they specifically selected a little bit older, but they kept this less than 6 weeks, more acute pain. And they actually increased their scale to even having 7 out of 10 as a pain score. And they had to have had an MRI or a SPECT CT showing an acute fracture. Their primary endpoint was basically a numeric rated score, 1 out of 10, after 14 days from the intervention. And they also measured at additional time points as well, up to 6 months. They also did the Rowland-Morris Disability Questionnaire. They did various quality of life questionnaires. They used a VAS, checked the analgesic use, and also for the patients that were inpatients, they actually looked at hospital stay. So at all time intervals, they found that vertebroplasty would result in lower NRS score as the second trial did. The way they did this was they looked at the proportion of patients with a score less than 4, and they compared it in the 2 groups. And so, you can see right here that at all time points, a higher proportion of patients in the in the vertebroplasty group reported a score less than 4. There was no significant difference in most of the secondary endpoints, which you see right here. And so they concluded that vertebroplasty is more effective than placebo at treating severe acute pain from osteoporotic fractures within the elderly. So a couple of the strengths, they used some of the methodology of the INVEST trial, but they were a little bit better about selecting the patients, more acute pain, more recent fracture, more severe pain, greater than 7. They didn't allow any crossover, and they also, if you look at some of the INVEST trial criticisms, some people say that there was not adequate fill of the vertebroplasty, but basically they would give maybe 1 cc and call it a day instead of really making sure that the vertebrae were filled. So that was one of the things that they were more specific about in this trial. And they had a higher enrollment rate, so the number of people that were considered evaluated for the trial were enrolled. So one of my main criticisms is that the data doesn't really make sense. So they demonstrated that they could show a lower NRS score that was significantly different between the two groups, but they couldn't show it on a VAS, they couldn't show it on a disability questionnaire. They didn't really discuss why that is, and it makes me wonder whether there's some statistical trickery involved. Also, these were performed at centers with high volumes of vertebroplasty, so you could argue that the people that are doing these procedures are very experienced, very good, and they're going to get better results than some guy out in the community that hasn't done a lot of vertebroplasty. So what does it mean for my practice? What do I take away from all this? Basically, I don't know that I can conclusively say that vertebral augmentation is better than conservative management for every patient. The jury is still out. The data is mixed, as I showed. But there's probably some patients in the acute setting where it works and actually has a meaningful clinical benefit. I mean, bringing that pain score down from a very high level to a very low level. And I think for the future, we need to work on better identifying who those patients are. And, I think, I still agree with, people doing vertebroplasty. I think, I've learned a lot from working with these patients. But I think we need to work on just showing that what we do actually helps people, and it's not just something that bills high RVUs. So these are the citations for the trials. Just wanted those available for anyone that wants to take a look at themselves. And I'll open it up to questions.
It was a great talk, Maunik. I think we're still waiting on questions here. If anyone in the audience has any questions, you can just type them into the question box on your right, and we'll answer them right now.
Or even feel free to speak up. We're all friends here.
Nothing as of yet.
All right, so I see a question. What do I think of the next step in terms of future studies? So, I think kind of what I concluded in my last slide, basically that there are patients that seem to benefit from this procedure, and there are also some people like the lady that I presented in my case that went from 11 out of 10 to 8 out of 10. And, I'm not really sure that we did her a lot of good, even though we did this big procedure for her. So really trying to figure out who those patients are. So I think, probably focusing on these acute patients, and you know, I don't know if it's a matter of like how we're asking the questions, how we're measuring. You know, pain patients, as I'm sure many of you guys know, can be a little bit of a handful, and so giving them a questionnaire may not be the best way of you know, taking these measurements. So I don't know if someone has, you know, great idea about how to better assess the pain. You know, that probably is you know, I think an avenue for future research. Let's see, has there been any reported difference in the adverse event rates between vertebroplasty and kyphoplasty? You know, offhand, I don't know that. I think there is a Cochrane level meta-analysis that compares vertebroplasty and kyphoplasty, and I can't remember what they exactly showed in terms of adverse events, but my gut feeling was that there wasn't a significant difference. And at our institution, you know, the decision to do vertebroplasty versus kyphoplasty, you know, it really comes down to what's available at the time. You know, we call our device reps in to do the procedure. They're helping us mix the cement and so on. And so if, you know, the Stryker guy's there, then we'll use their kit, and, you know, maybe it has a balloon, maybe it doesn't. We don't tend to differentiate too much. You know, in the case that there are tumors, sometimes we'll do a tumor ablation with the vertebroplasty, and so you know, that is a specific kit, and so that one actually, or it is actually a kyphoplasty.
There's another question here. Do you think this concept can be applied in the future to other types of fractures?
So I think you know, the idea of using a needle to inject bone cement definitely has been done for other fractures. Part of the issue is that you know, a lot like other things in IR is getting the referrals. So you know, somebody has a fracture, they're going to be consulted by ortho before they get to us, and you know, most of the orthopods will you know, figure out what they think is the best management. I do know that there are some orthopedic surgeons that do inject bone cement percutaneously in other places. And then also there are orthopedic surgeons and neurosurgeons that do kyphoplasty and vertebroplasty in the community as well. So, you know, it certainly could work in other places, but I don't know of any specific examples that radiologists routinely do. If anybody does, feel free to chime in.
I don't think that we have any more questions here, so unless anyone else has another question, you can go ahead and type it in now. Otherwise, Maunik, thank you so much again. I think we can just wrap it up now.
All right, thank you guys very much for tuning in.
All right, guys, have a good night, everyone.
All right, good night.